Hit the subscribe button or visit us at auau.auanet.org.
Thank you, everyone, and thanks again to the organizers. My name is Josh Lang. I'm a GU medical oncologist. I care for patients with metastatic prostate cancer in my clinic, and really honored to be able to be a part of the faculty and present information and data on the use of combination hormonal therapies and chemohormonal therapies for the patients with metastatic hormone-sensitive or castrate-sensitive prostate cancer, as well as the management of oligometastatic disease. This will be a joint presentation with my colleague, Dr. David Jarrard. And I understand that Zoom has changed our settings just in time for this, so I'll be, as soon as I have control, I'll advance the slides. All right. There we go. All right. So in terms of an overview of this talk, we'll talk about the role of hormonal therapy and chemohormonal therapy for patients with metastatic hormone-sensitive prostate cancer, the use of androgen receptor pathway inhibitors in combination with docetaxel, as well as how we manage patients with low-volume low-volume metastatic hormone-sensitive prostate cancer and intact primary tumors. And then now how we're moving towards triplet therapies for these patients as well. I think as most of the folks on this call know that patients, unfortunately, we're seeing that there's an increasing incidence of patients presenting with metastatic disease at first diagnosis. The reasons for this are multifactorial, certainly related to changes in PSA screening guidelines, but that's its own separate talk. So let's talk about our first patient here. So this is a patient with a high volume metastatic hormone-sensitive prostate cancer. So this is a 62-year-old gentleman who presented to my clinic. He initially went to his primary care physician complaining of back and leg pain. He ultimately went through an extensive workup and was finally found to have his PSA checked. It was elevated to 85 and an X-ray showed lytic lesions. His staging bone and CT scans showed nodal disease as shown in the CT scan on the right, as well as widespread bone metastatic disease in the bone scan. He did undergo a diagnostic prostate biopsy with a Gleason 4+5 tumor found in 8 out of 12 cores with greater than 70% involvement. So as mentioned before, the incidence of patients presenting with metastatic castrate-sensitive or hormone-sensitive prostate cancer, previously thought about 3% of all new diagnoses, is now up to 8% per year. We know that the use of androgen deprivation therapy alone in this situation, that the average time to developing castration-resistant disease is approximately 12 months, with a survival of 3 years. So this is a patient population critically in need of new therapeutic interventions. So we've since had multiple phase 3 trials looking at different combination strategies. The first ones were those presented using docetaxel chemotherapy, tested in the Charted, STAMPEDE, and GETUGE-15 trials. The Charted clinical trial randomized patients with metastatic castrate-sensitive prostate cancer to receive ADT alone or ADT plus 6 cycles of docetaxel chemotherapy. And what they found was that there was a dramatic improvement in median overall survival, 57.6 months versus 47.2 months for ADT alone. And for context, the median improvement in survival with docetaxel in the castration-resistant setting is just over 2 months. So this was dramatically superior when using chemotherapy in this clinical situation. They found in this trial that the majority of the benefit was for patients who presented with high volume disease, as defined as 5 or greater extraaxial bone metastases or visceral disease, including liver or lung metastases. While patients with lower volume disease, those patients who may have 1 or 2 bone metastases or enlarged retroperitoneal lymph nodes, did not have that same improvement in survival. So this really became a key stratification factor that was evaluated in really every single phase 3 trial that's been done in this particular clinical situation, including the STAMPEDE trial. And for those who aren't familiar with the STAMPEDE trial, it really is a fascinating design where they have continuous enrollment to what's considered a standard of care arm, and then they continue to add multiple new arms. And in this case, they considered the standard of care at that time of ADT alone, with or without radiation therapy to the primary tumor, followed versus the experimental arm of the addition of docetaxel. And importantly, they found an almost identical improvement in overall survival with the addition of docetaxel and ADT in this clinical situation. In terms of docetaxel itself, it's an IV infusion given once every 3 weeks at 75 milligrams per meter squared. There is no use of prednisone for men in this situation, though it is used in the castration-resistant setting. Dose reductions are absolutely permissible, and the major concern really in this patient population is neutropenia and neutropenic fever, which is really very easily managed with the use of G-CSF or other growth factors. In terms of a disease evaluation, we use PSA testing every 3 weeks, and a bone scan and CT scan at baseline is indicated, or also if patients have a rising PSA, 2 consecutive increases in the PSA consistent with castration-resistant disease or clinical progression. Note that more expensive molecular imaging, such as PSMA PET scans or others, are not used to evaluate response or resistance to therapy in this clinical context. It has not been shown to be reproducible enough and has a risk of false positives for change that may not be related to actual disease progression. In terms of toxicities in these trials, as I mentioned, febrile neutropenia is the biggest concern in 6.2% of patients, while other less common side effects, diarrhea, fatigue, stomatitis, etc., have also been noted. Again, this chemotherapy is much better tolerated in the hormone-sensitive setting than the castration-resistant setting. So coming back to our patient, he was started on morphine for pain control because of his extensive disease. He started ADT followed by docetaxel within 4 months, and his PSA had a dramatic response and his PSA natered quite well. So I'll hand this over to Dr. Jarrard.
Thank you, Dr. Lang. So we'll continue talking about this kind of patient, and this is, again, an individual with oligometastatic prostate cancer, so lower volume disease. His PSA several years ago was 6, and it's now 32. He had a biopsy, and it was found to be a Gleason 8 cancer that was found in 6 of 12 cores. Notably, he does have a history of cardiac stent and an MI, a heart attack, but is active. He has significant lower urinary tract symptoms, has a history of urinary retention, does not have any bony pain. But what we see here is pelvic and retroperitoneal lymphadenopathy, and this is shown on the right, and one rib lesion that's consistent with metastatic disease. So these androgen signaling inhibitors are now applied to this metastatic hormone-sensitive prostate cancer space. Abiraterone was one of the first that was utilized in this space. And again, to remind you, it blocks CYP17 and can create issues with salt retention and other side effects, including liver function enzyme alterations. Abiraterone in the Latitude study was really the first one that was, at the time, fairly profound, the improvement in survival in these patients. Again, these individuals were hormone naive, and they were randomized to abiraterone plus Lupron versus Lupron alone. Enzalutamide in the Arches trial also showed a benefit in this clinical space. 67% of the patients had distant metastases at diagnosis, and 63 had high volume disease. So this was a fairly high, metastatic group. What we saw was improved progression-free survival in all of these groups. So it didn't matter about the volume of disease. And indeed, a subset of these individuals had prior docetaxel, and they still responded. Side effects were similar to what had been seen in other drug spaces, and this received FDA approval based on these positive results. Apalutamide was the third drug in the Titan trial to show benefit in this space. And as expected, we did see an increase in rash and hypothyroidism in these patients. So this is a summary table looking at all of the studies that have been done. Again, focusing on our AR pathway inhibitors, you can see here on the right the hazard ratios, which were all significant for this subset of patients. So one aspect is control of the local prostate, and is there potentially an advantage to this? So let's shift our case. This is a 68-year-old with oligometastatic hormone-sensitive prostate cancer, minimal lower urinary tract symptoms, and he's very healthy, again with pelvic adenopathy and one suspicious bone lesion. So with oligometastatic disease, in the setting of limited metastatic sites, it has been proposed that local therapy can be of benefit. And really, when it comes to oligometastatic disease, it's related to the number of mets you can reasonably treat, either surgically or with radiation. There have been, and this consists of a prostate-directed therapy, node and metastasis-directed therapy, and it's often combined with some sort of systemic therapy. Its goals include delaying the need for androgen deprivation therapy, but really survival benefit has always been the big question. Now, we have some retrospective data demonstrating that there is improved survival with prostate treatment in advanced disease. And these are retrospective studies looking at SEER databases encompassing thousands of patients. And what you see on the upper right is that with radical prostatectomy or brachytherapy, they were using that for radiation, they showed a marked improvement in patients that did not have treatment of the primary prostate. This was also shown in a separate study on the left, again retrospective. And this really suggested that treatment of the prostate may decrease subsequent metastatic shedding of cells. The first study to really look at this definitively was one of the STAMPEDE arms, looking at ADT plus or minus radiation therapy for patients with low volume metastatic hormone sensitive prostate cancer. And overall, in patients with higher volume of metastasis, as defined by the Charted study, you did not see a benefit as far as overall survival. But interestingly, overall survival was improved in those patients that had a lower metastatic burden. So survival improved from 73 to 81% at 3 years in those low metastatic patients. The hazard ratio was 0.68. And this had been previously hypothesized in the Jarrard trial, which had demonstrated, again, in a secondary analysis that lower volume patients benefited from radiation therapy to the prostate. So in both of these subgroup analyses demonstrated improved survival in patients with low metastatic burden. There's those two retrospective trials suggested that with surgery, we may see perhaps even an improved benefit. There's several large studies that are undergoing right now, including the SWOG 1802 trial, looking at this question. Obviously, our improved imaging with PSMA PET is going to help us with patient selection. On the right here, you see a patient that had a negative CT scan, but with PSMA PET, we were able to see a single metastatic lymph node that was defined by PSMA PET. So in summary, there are multiple options for metastatic hormone-sensitive prostate cancer. There's chemohormonal therapy with docetaxel. There are these androgen receptor axis targeted drugs and third-generation AR inhibitors. And more recently, there's been a lot of excitement about so-called triplet therapy. This was a major emphasis at the recent European Society of Medical Oncology meeting several weeks ago. But Dr. Lang's going to talk a little bit more about choosing these pathways and combination pathways.
Thank you, Dr. Jarrard. So moving on, I think this is where, in the interest of time as well, I really want to spend some time focusing on exactly that discussion. Especially because there have been significant changes in terms of what we're using in terms of how do we approach treating patients with this type of disease. One moment while I get control here. And maybe I'll just talk a little bit about this while I wait for slide control to come over. So in terms of how we treat patients now, this is, you may have seen recently that the two large trials were conducted. One, the ARASENS trial, looking at the use of darolutamide docetaxel in patients versus docetaxel and ADT alone. Another study, the PEACE-1 trial, a kind of a complex study design, but essentially rather than using darolutamide, they used abiraterone. And importantly, what they found in those particular clinical trials was a significant improvement in survival for patients who received the triplet combination compared to those patients who received the chemotherapy, ADT plus chemotherapy alone. So this really comes back to a question that we previously faced of when should we use docetaxel versus an androgen receptor pathway inhibitor? And now what we have is clear data from these clinical trials. Again, the Peace 1 trial and the Arisens trial is shown here, that the use of ADT docetaxel with an AR pathway inhibitor is significantly better than ADT and docetaxel alone. Now, one of the really important caveats to the trial design is that they did not have an arm using ADT with an AR pathway inhibitor alone, which leads us, unfortunately, with the question of saying, who are the patients that would benefit from ADT plus an AR pathway inhibitor versus that, so a doublet therapy versus the triplet therapy. Now, this is a really important distinction. We spent time talking about the impacts of ADT and how we give docetaxel and what are the toxicities and side effects. Again, all those same toxicities were also observed in triplet therapies as well, though the incidence of fatigue was higher, not unexpectedly. But it's these results that just very recently, in the latest update with NCCN, actually removed the use of ADT and docetaxel for men who present with metastatic castration-sensitive or hormone-sensitive prostate cancer. So really what we want to do is focus these either on a doublet therapy using ADT plus an androgen receptor pathway inhibitor, or going with a triplet therapy combination, especially with these clinical contexts. Now, how do we pick which of those patients will most benefit? There's a lot of correlative studies and retrospective analyses that are going on right now. So I'm hopeful that early next year at GU ASCO, we'll have much more data to present and discuss on this particular topic, especially when we think about the impact of specific genetic mutations. And coming back to Dr. Gamello's presentation, we expect the patients who have high-risk genetic mutations, P53, RB, P10, and BRCA mutations, those are patients that would likely specifically benefit from the use or the addition of docetaxel. And again, really highlights the importance of genetic testing for all patients with metastatic prostate cancer. It's absolutely critical. And using the primary tumor biopsy in this situation for men who present with metastatic disease is very reasonable.